Hello, everyone. Welcome, and thank you for joining us for the Virtual Learning Hour Principles for Improving Patient Safety Measurement. My name is Sarah Kramer. I'll be your host for today's call. For those who attended the live program, the program was accredited for 1 CEU for physicians, nurses, pharmacy, and certified professionals in patient safety recertification. All faculty have disclosed in accordance with the rules and regulations. This criteria that you can see on the screen, which is register for the event, log into the event, and attend the entire event, and complete the online evaluation survey, is for those who attended the live event. Our learning objectives for today are to outline the challenges facing measurement in patient safety, explain the importance and impact of more effective measurement in patient safety, and describe the 8 global principles for measuring patient safety. I'll now hand it over to Madge Kaplan, the Director of Communications at IHI, for the next section.
Thanks so much, Sarah. Well, hello. Thank you for joining us today. We're so pleased to have you with us for today's special Patient Safety Awareness Week Virtual Learning Hour. As many of you know, Patient Safety Awareness Week is an annual recognition event run by IHI, and it's intended to encourage everyone to learn more about healthcare safety. This year, IHI is focusing on 2 areas that we believe are especially important to advancing safety: the need for more effective measures of safety, and safer transitions for patients when they go from one care setting to another. The 2 are connected. Existing safety measures don't capture a patient's entire health journey across the continuum of care today, and patients are at their most vulnerable when transitioning from hospital to home or to a post-acute setting, or even between departments within the same hospital. So on this virtual learning hour, our speakers today will share a substantive overview of the challenges that are surrounding patient safety measurement and discuss opportunities for improvement. And then, mark your calendars, we invite you to join us for a Twitter chat on Thursday, that's this week, which will focus on effective ways to improve safety during transitions in care when patients move from one setting to another or to home. We're joined today by 3 leaders in patient safety. You probably know them well. Sitting across from me in the studio here in Boston at IHI, Don Berwick is President Emeritus and a Senior Fellow at the Institute for Healthcare Improvement. On the line, we have Helen Haskell. She's the President of Mothers Against Medical Error and Consumers Advancing Patient Safety. And we also have Nick Glasinga. He is the strategic lead of the Healthcare Quality and Outcomes Program at the Organization for Economic Cooperation and Development, often referred to as OECD. And Nick is also the convener of its Working Party on Healthcare Quality and Outcomes. I'm also pleased to share that Helen and Nick also served as co-chairs of the Salzburg Global Seminar, Moving Measurement into Action, Designing Global Principles for Measuring Patient Safety. And that's what we're going to be talking about on today's session. So, without further ado, let me hand things over to Don Berwick to begin today's virtual learning hour. Welcome, Don.
Thank you, Madge, and thank you all for joining this. I'm delighted to be with you, and I think my biggest job is to get out of your way as fast as I can so you can hear from 2 of my deeply admired colleagues, Nick Glasinga and Helen Haskell, who are going to talk a bit about the findings and results from the Salzburg seminar that Madge mentioned that I had the privilege to serve at. But I thought I'd take just a couple minutes to put this conversation in context. I think those of us who've been working on patient safety now for decades probably share in common an impression that things are not as we wish they would be in the safety movement. The sciences of safety have evolved. The epidemiology is well known. We know a ton about how patients get hurt by avoidable errors and mishaps in their care. We have evidence from other industries as to how to intervene, and lots of great bright spots in healthcare where progress has been made. But so far, I think, and I'll ask Nick and Helen to say say their own point of view, that the response matches the depth of the issue. I don't want to minimize the COVID-19 situation. It's a global tragedy, economically and medically, and hopefully we're going to end up getting through this without the worst case scenarios evolving. But you're watching a global mobilization about this bad viral problem. I think you may know the data so far, though. In the United States, for example, I think the number of people that have died from this infection still is under 100 nationally. If you take the Institute of Medicine report in the United States from 2001 and 1999 to Eris Human, and the estimates of the consequences of injuries to patients in healthcare, the numbers probably haven't changed that much. We're looking at something, I'll say roughly 50,000 deaths a year in this country from errors in care. That's about 150 a day. It would not be overstating to say that about 5 times as many people die in the United States from patient errors every single day than have so far died in the entire 3-month trajectory of the COVID-19 epidemic. I don't mean to minimize the COVID issue. I'm desperately concerned about it, as you are. But we have another epidemic here that's been around for decades, which is taking the lives of people we know every day. And although we see some good-hearted responses and some terrific science, it really is rather rare to enter a C-suite in an American hospital, let's say today, and find intense energy devoted at the strategic level to the improvement of patient safety. And it's a bigger problem than that, because I continue to believe, somewhat to my colleagues' annoyance, that whenever we say quality and safety, we're making a grammatical error, because safety is a quality and only one of the qualities. One could argue, in fact, that the concept of safety is almost coextensive with the concept of quality, and so I somewhat provocatively in Salzburg created this slide. Is there any component of excellence in healthcare that it's not a safety issue? If a patient with a condition, a disease, gets the wrong medicine because we're not using the proper protocol, is that a safety problem or a quality problem? If a person has a question that doesn't get answered, is that a patient-centeredness problem or a safety problem? These dimensions overlap a lot, and when we begin to talk about safety, we've got to recognize we're at the edge of a very big terrain of defect in healthcare. The next slide shows you a little bit of a diagram that I came up with at the Salzburg seminar, which it's trying to clarify how big I think this issue is of the relationship between safety and quality. If you take concept number one, which is there's this thing called safety and a thing called quality, and they're different, that is not intellectually honest. It's not proper. Safety is not a separate thing from excellence. It's one of the components of excellence. You could look at it as diagram 2, which is there are different worlds that overlap in issues like reliability or worry or diagnostic error or delay or evidence-based care. I don't see it that way either. I don't think that this is just a matter of overlap. I see it much more as shown in diagram 3, where we have a larger concept of quality, or maybe we should use the word excellence, or matching the work to the need, which has many, many dimensions. Effectiveness means that we use the science. Timeliness means we don't keep people waiting. Equity means that race and ethnicity and language and background don't determine your health. Efficiency means we're not wasting. Patient-centeredness means every patient's the only patient, and what matters to you. And then there's safety, which means we don't hurt you. That's the way I see it, that the safety conversation we're having is part of a much larger terrain of excellence. That's actually very helpful, because you need an entry point, something that's charismatic and understood, where you can begin to have the broader conversation of excellence in all its dimensions. And safety is a terrific way to enter that broader conversation if you keep in mind that there's a broader terrain. And of course, this gets absorbed even further in the triple aim, which has to do with better care, the top of that triangle, which is same as what I just showed you under item 3. But it also includes working upstream on health and also working on reducing waste overall in the system. My point is, when we talk about safety, we are at the entrance door to a very large conversation about the overall terrain of excellence in healthcare. I welcome that. It's a terrific place to start, but keeping that larger context in mind might be helpful. Now, this webinar and the SALTWORKS seminar are largely focused on a tool, on a mechanism, a way to think about working on more effectively on this element, safety, and especially through the window of metrics, measuring in such a way as to accelerate progress. And I would say, given my earlier comment, perhaps intensifying or increasing or awakening leadership energies so that we can work on making care safer as a strategic value in healthcare that is not done as a program down the hall or a project in the annex or a Tuesday morning meeting, but is actually at the heart of the strategy of what we in healthcare and the public we serve are devoted to. That's the context. Madge, let me turn it back over to you and to Helen and Nick to get us to some of the much more valuable details.
Thanks so much, Don, for setting some context and framing. And let's now go to Nick, and Helen will follow after you, and I think you'll go a little back and forth, and Don will come back. Okay, Nick?
Thank you very much, Madge, and it's a pleasure to be on this webinar. Thanks for the opportunity. And I want to follow up on what Don has been saying as the background on why we should strengthen the measurement on patient safety in giving a little bit of information about the Salzburg program. As you see, the title of that program was Moving Measurement into Action, and that really explains what the meeting was about. Measurements is not just about reliability and validity, it's about whether measures are actually used in an active way for improvement, control, monitoring, whether they are built into the system in such a way that they're a part of feedback loops. And that was the perspective that was taken in the Salzburg Global Seminar Program. Actually, the Salzburg Global Seminar Program runs already since 1947. It addresses all kinds of different topics where leaders and experts come together to sit together for quite some time to think something through systematically. In this case, it was initiated by the Institute of Healthcare Improvement. We had 44 participants from 18 countries covering 6 continents, and actually had the privilege of being together for 5 days in September 2019. And it was very good to see that the group that met to rethink the measurement of patient safety was a nice mix of people who come from research, who come from practice, and who come from different professions, nursing, medicine, allied health professionals, as well as policymakers and managers. So although you see here a very nice picture of a group of people, I can assure you that although these surroundings were extremely nice, we made very long days of having intensive discussions and picking each other's brains or trying to address this challenge of making measurements in patient safety move into action. The goals of the Salzburg seminar that was said beforehand was, on the one hand, to design innovative recommendations for how patient safety should be measured, while acknowledging challenges and opportunities within our current systems of measurements, but try to come up with some global principles for the measurement of patient safety that are meaningful for all stakeholders in all care settings around the globe. And of course, that's a very broad goal to set. It also showed what we hope the global principles will do. They should help the various stakeholders in the system, and then you have to think about patients as well as healthcare professionals, managers of healthcare institutes, policymakers, regulators. All these stakeholders should be able to use these principles to select a comprehensive set of safety measures that are fit for use. And again, this term fit for use is crucial. It's similar to the title Moving Measurement into Action. It says that it's not such a thing as a universal best patient safety measure. What is necessary is that in different settings, given the context, you have to select a set of measures that make sense and that are actionable and that are really linked to feedback loops that help monitor and improve safety. And although this seems very obvious, what we saw when we started discussing the present situation with patient safety measurement, we saw that it's very much focused not only on clinical domains, but tends to accumulate the number of measures, make them more precise, make better case mix adjustments, and as a result, end up with a lot of measures for which that not always are linked directly to improvement cycles and to learning. So we hope these principles should help stakeholders to make these selections. They should also cover safety measurements all through the journey of the patient across the continuum of care. And this, of course, underpins that, again, patient safety is not only relevant in high-risk situations in clinical settings, it is as important in areas like primary care and long-term care. Coming from the OECD, over the past years, we produced various reports on the economics of patient safety, and they address again and again that the burden and the economic consequences are not just in the clinical sector, they are as important in primary care with wrong diagnosis or medication errors as in long-term care with, for example, patient falls and bed sores. And the third aim of the global principles is to build safety measurement into the management and policy processes in a way that assures effective reduction of risks and harm. And that kind of builds on what Don already was saying. You have to work upstream. It's not just measuring harm and reacting on that. It's trying to look upstream what the risks are and how to assess risks in the whole healthcare system. So the global principles we try to develop should have a broad application. And in this figure, you see the different purposes. And of course, that is quite ambitious to have principles that are applicable across diverse settings and contexts, across different stakeholders, populations, through our patient's life trajectory and across the care continuum. But we think we came up with 8 principles that will help to address this agenda of moving measurement into action. Helen, can I ask you to address the first 4 principles?
Absolutely. Thank you, Nick, and thank you for that introduction. So I will go fairly quickly through the principles so that we will have more time for discussion later. But the first principle really is the one that Nick has been talking about for the past few minutes. This is our overarching principle that measurement should acquire knowledge, it should be actionable, it should be meaningful, it should lead to improvement. And I think really the most important point in this one is that we must use measurement to create a learning system. It's probably the biggest challenge we face. It's a cultural challenge as well as a procedural and a policy one. It's something we're still learning how to do well. I think the encouraging part is that there is growing consensus and understanding and willingness that we need to work toward this concept. Subsets of this principle are that we must have measures that are evidence-based, that can be acted upon, that are balanced and focused, and can be acted upon in the short term that tell us about risk as well as harm. And I think that we also want to move to measures that matter to people who are on the sharp end of healthcare, to patients and staff. And that's going to mean that we include a lot of measures on things that we haven't looked at as closely before. Things like culture, communication, behavior, the softer elements of human relations that are really the fabric that stitches the whole enterprise of healthcare together. Could I have the next slide, please? So our second one, and I think it's important that this is our, really leads after the overarching principle, is that effective measurement requires the full involvement of patients, families, and communities within and across the health system. This was one of the big takeaways from the Salzburg seminar, the importance of the patient voice in measurement. As Don put it, devolving power to the patient. I think it's safe to say that this concept really suffuses all our recommendations. The idea that we really have reached a point where we can't move forward productively without the voice of the end user. Patients have a different view of health and healthcare and the health system. Patients value their own global well-being as opposed to short-term functioning of a particular part of the system or a particular treatment. But in the end, that is the point of view that needs to be captured. Patients need to be involved in all aspects of measurement, from conception to design, and also as contributors of data. This is something that we really haven't thought about as much, but patients contribute different things from their providers. They see things differently, often in very elementary ways, and it's the concept that we have to capture. Patients are definitely, evidence shows that patients are reliable contributors of data. And finally, safety measures must be transparent and readily accessible to patients and families, and I would add communities. They need to be accountable. Healthcare needs to be accountable to its users and to the communities in which they live. Next slide, please. So safety measurement must advance equity. Equity is the absence of avoidable, unfair, or remediable differences among groups of people. I think this includes variation in settings where different groups of people receive their care and ways in which those could be standardized, measurement could be standardized in spite of differences in resources. As Nick pointed out, this is really a big challenge, how to find universal measurements. I think it's going to take a change in our thinking that will benefit us all once we find things that work everywhere. Then we will have a much clearer idea of why they're working and how they're working. I think it's important that we be sensitive to cultural, ethnic, and other differences, while also measuring for it specifically. Next slide, please. And the measures that we select must illuminate an integrated view of the health system across the continuum of care and the entire trajectory of the patient's journey. So both longitudinal and horizontal and through the patient's eyes. This returns us to the idea of the patient as end user. The patient is really holding the keys to answering questions about long-term effects, about interventions. And the patient as the only person who traverses the entire healthcare system and who can see issues that healthcare providers are not able to see in their smaller parts of it. Patients really have unique knowledge of how well the system functions as a learning system, which is something we are not presently measuring effectively at all, I think it's safe to say. So things like, are our root cause analyses finding out the real causes of harm? Are we disclosing harm to patients as we should be? And are patients being treated respectfully throughout the system, and especially after they have suffered harm? I think these sorts of measures give insights into the deep culture of an institution and a system, and they lead us to the possibility of true improvement at a really visceral level. Thank you, Nick. I'm going to turn it back over to you for Principle 5.
Well, to continue with Principle 5, of course, we have now the possibility with technologies to collect data and analyze them real time. And that should really be picked up to help proactively identify and prevent harm as often as possible. What we experienced during the Salzburg seminar was lots of examples of various countries where available data are used in an intelligent way, real time, to assess risks and to predict risks. And of course, this is linked to the broader agenda of digitalization and informatization in healthcare, but especially for the safety agenda, this is an area where we could really make progress over the coming decades. And one point should be raised here. This only works if we set it up in a way, of course, that is concordant with our present rules for data security and data privacy. And that is in many areas in healthcare still sometimes a hindrance. But especially when it comes to safety monitoring, the technical possibilities are there, and we should really maximize on the possibilities that are already available today. That also means that the measurement systems should, of course, be based on evidence, but will evolve and adapt continuously. Measures that were useful 20 years ago might be useful in some settings, but they are not there for eternity. As I tried to say in my earlier interventions, they should be fit for purpose. And that also means that we have to reassess regularly the measures that we are measuring and reporting, just to see whether they are actually used. And on the other hand, we should select measures not only based on quantitative notions, but also on qualitative data that is applicable to the specific context in which care is provided. Keeping the data, the measures, and the knowledge about the setting close together to creating a feedback loop that is fit for learning is essential if we want to make progress. And that means that setting up measurement systems that are focusing far more on collecting data over a long period of time and having feedback loops that take more than 6 months and sometimes up to a year can have their use, but only for a limited series of purposes. This links, of course, to the fact that the burden of measures collected and analyzed must be significantly reduced. Part of the analysis we did in Salzburg is that we saw that over the past decades, we have institutionalized patient safety and we have formalized patient safety measurement, and especially with a focus on harm. But this has become so big that in many settings, it's not giving us the results that we wanted to have. So we should really try to be smart and see how we can use the existing data collection in such a way that it, on a continuous basis, can help us to make a distinction between signal and noise and react effectively to risk situations. And that brings me to the last, but surely not the least principle, the one of culture. It has been mentioned both by Don and by Helen. Stakeholders must intentionally foster a culture that is safe and just to fully optimize the value of measurement. We now are in a place where over the past 5 to 10 years, most of the leaders in healthcare and people studying patient safety have underpinned the crucial importance of safety culture. Also, the measurement of safety culture can be part of that. Presently, work is on the way at the OECD to try to have international comparisons on the way how safety culture is captured in things like handover and experienced patient safety by workers in healthcare. But it's crucial that if we are not able to build this overall safety culture as it is set up in other sectors, we will not achieve the safety results we want to achieve. that's what we wanted to share with you. And I hope these 8 safety principles are inspiring, and happy to address further questions.
I think we're going to go back to you according to my instructions. I thank you very much, Niek and Helen both. Some thoughts from Don as we tee up for Q&A with all of you.
Well, the Salzburg statement is available to you, as you can see on this slide, and we hope you'll look at it. Niek and Helen have summarized some of these really important findings. We were looking for findings with edge, things that are actually having us think differently about measurement. If you listen to Niek and Helen, there are 8 principles. I want to pick out 4 or 5 of the key points that I think lie within the principles. The first, articulated by Helen, which is the crucial role of patient voice. Every minute at Salzburg, we were conscious of the potential help that patients, families, and communities can give to not just to the patient safety measurement enterprise, but to the energy and the wisdom of the changes we're making. So increase patient voice. For those of you on the line, that means get the people in the room. You really need proximity to patients and families to make this work properly. The second, I hope you sense, is a migration of the psychology of metrics away from judgment and toward learning. There is a strong sense in these principles that we need to adjust the way we're viewing measurement so that the people that have to make the changes regard it as friendly and helpful to them, because it's giving them information at cycle times and with a sense of what's happening on the ground so they can put things to use. I chatted in a question for you all, which is if there's anyone listening in who can chat in an example or 2 of a measurement that really did help you, we were able to move it directly into change, I would love to hear that. That relates to a third point, which is the technology of measurement. I think there was a general sense in Salzburg, and Niek and Helen will correct me, of kind of both too much and too little. Too many measures. There was a strong belief that we're kind of battering the workforce and organizations with a lot of measurements that aren't being used, but too little attention to metrics that actually can be used in short cycles and locally to actually improve care. And then I think the last piece is one that I want to be careful how I phrase it, but in some fundamental way, a measurement is waste if it's not used. And there's a insensitivity we felt to the burden of measurement and the costs of it, so that it kind of has to pay its way, not financially. I'm talking here about making everyone aware that when measurement is pushed into the system without utility and an intention to act on it, it's just another burden, and we need to be more respectful of the workforce and of the cost of measurement in order to be able to make measurement actually be as useful as it can be. We are interested in your comments and your suggestions about how to make things useful. And also, I'll say again, any examples you have where metrics have been moved to action in your organization or where you're aware of a story, we'd love to hear them. There's a question from Hassan Abid, which I just lost here. Did we include patients when working on driving these global principles of the patient safety measurement? Helen, do you want to comment on the voice of patients at the Salzburg seminar and what you saw and what you wish you might have seen more of?
I was actually quite elated at the patient voice at the Salzburg seminar. We had patients from around the world. We had people from very resource-poor settings, as well as from North America and Europe. And we had people from every continent. It was, I thought, quite effective. And when you have that conversation with people from such diverse backgrounds, you really learn a lot. It really levels the playing field as to, what the basics of measurement are. So I think that really accounted for a lot of the patient-centeredness of our recommendations, was just this substantive patient voice.
Plus, of course, your voice, Helen. You were quite an eloquent spokesperson.
Oh, well, that's terrific. Don, I'm just going to maybe relate some things. There's a couple questions here about sort of real-time measurement, technology that can help that, and feasibility of that. And there are a couple questions here about that. Nick, could you speak to, say a little more about that and whether or not we can point to some good examples right now?
Yeah, sure. Well, of course, it's the general principle, and it of course is very closely related how far countries are with having not just electronic health records, but also automated patient records. Just to give some examples, the whole movement with trigger tools is of course an interesting one. So, are there ways to automatically go through your electronic health records and signal things? That's one approach. And what I remember from the Salzburg meeting was especially presentations from Northern Europe and some from the US and Veterans Administrations, where more and more of these tools are applied. Of course, when it goes to risk assessment beforehand, we probably a lot of people are familiar with the data systems for intensive care. But what we found out in discussing broader is that it has far more to do in when you design these systems. So when you have your electronic health records, you have the linkage with the data systems in primary care and in long-term care. You are thinking about getting signals from those data. You really need a good structure that helps you to get this secondary data analysis in place. And what I know from my OECD work is that an increasing number of countries starts thinking about this, but there are also still a lot of countries where this thinking is not that far developed. So the emphasis is very much on the data privacy, data protection, and there's less regulatory frameworks for secondary data use. Will, especially for patient safety issues, and especially for patient safety issues across the different healthcare sectors, that would be a way forward.
Thanks, Nick. I wanted to go back up a little bit and get to a question that Mark Graber asked or asserted here, whether there's too much focus on management and in this realm and not enough on diagnosis. I thought, let me start with you, Don, on that.
Yeah, this is a very topical issue. Diagnostic error has become a surface up topic within the safety movement. There's actually a society now that just focuses on diagnostic error. We have a new report from the National Academies of Sciences, Engineering, and Medicine on diagnostic error. It appears, I don't think we've been ignoring it, but these reports do show that it deserves more attention. And we with respect to mitigating the effect of diagnostic errors, we still are a little bit short of theory here about understanding, probably from cognitive psychology and semiotics and other fields. So I think there's a wonderful cutting edge piece to this movement around diagnostic error and its mitigation. The Gordon and Betty Moore Foundation has recently started a collaborative project around the country on diagnostic error, and I think we're going to see a lot of motion in that space. So thank you, Mark, for that comment. And while I have the floor, there are a couple of questions about kind of immediate use of metrics. What does that look like? I'm sure Nick and Helen might have further comment, but let's notice, for example, the question from Ann McCullough. When you refer to metrics to prevent harm in the spot, are you suggesting daily live chart review of the electronic health record? Yes, maybe not that exactly, but if we are in really the learning organization mode, which is now widely written about, then with respect to things that go wrong, there would be very immediate use of metrics and detectors really on an hourly or daily basis at the sharp end where care is being given, where it becomes part of the culture to ask what has happened and even what could happen. There's some really great innovation on anticipatory huddles. Begin the morning by saying who's in the unit right now, what could go wrong with them, and to think ahead of the game. And there's very exciting work on that going on in situational awareness. Cincinnati Children's Hospital Medical Center, for example, has been doing terrific work with really good results. So yeah, we're really talking about a different measurement an additional measurement theme of instantly available, useful narrative and quantitative metrics right at the sharp end. I'm sure Nick and Helen, you may have more to say about that, the utility of measures and how to make them more useful in the direct delivery of care.
This is Madge, and I'm just going to jump in for a second. Thank you, Don. Vicki, here in our studio, just put in a nice link to just even some of IHI's information on the global trigger tool for measuring adverse events. I want to make sure people can see sort of some foundational information about trigger tools and how they work. So, Nick, hold on, and maybe I'll just ask Don to...
About the trigger tool, yeah. So let me explain the global trigger tool. I think it's one of the real breakthroughs in IHI's work. I attribute it to Fran Griffin and Dave Klassen and others here that have been fundamental in its development from Frank Federico. The idea here is that we really could use some kind of roll-up overall systemic measure of how much is going on, how much harm is going on. We don't really have one. The closest we have now is the global trigger tool developed by IHI colleagues about a decade ago. It was actually tested by Brent James and others in Intermountain Healthcare and several other organizations, and it does appear at the moment, I guess calling it the gold standard is a little overstating, but I'll say you detect more injuries and errors with the global trigger tool than any other currently known mechanism. The problem is it's hard to use. It's chart review based. It's worth it, but it's tough. I encourage you to read the white paper. Recently, Dave Klassen, Frank Griffin, and others have been arguing strongly for automating the global trigger tool, that is, embedding in electronic records surveillance based on that model. And I really do think we're going to see this happen. I think in the next few years, you're going to be able to, in an electronic record environment, use the logic of the trigger tool to come up with a pretty good overarching assessment of things gone wrong.
Thanks, Don. Nick, maybe you could also speak to, it does get to real-time views of what's going on, and obviously, or maybe not so obviously, but daily huddles are certainly a part of this right now. And I'm just wondering, we do have a comment in the chat of somebody who's saying, well, it's still after the fact. So what we're measuring is something that occurred or very likely occurred, as opposed to being able to prevent or to do any kind of predictive thing on risk. And could you maybe offer some thoughts on that in terms of measurement, maybe in the more predictive realm? Thanks.
Sure. No, I think that builds on what Don is saying. And when I say real-time measurements, what I mean is not necessarily only the ultimate outcomes of harm, but especially the various risks and the compilation of different risks. So that was surely in my mind when I was speaking about real-time reporting. The thing is, of course, what risks do we want to articulate? What do we build into our systems? And how do we get the signals visualized in dashboards or other ways that come to us? I saw the remark by one of the participants, we should also look at the visual representation. But that's totally true. And a lot of that science, especially in other fields, is there. So on the one hand, I think we should not only focus on the ultimate negative outcome of harm and trying to collect all these data, we should try to assess also the process side and the risks and the occurrence of risks and how to signal that and how to mitigate it. And yeah, that's probably a way forward of using technology. Apart from that, you have the predictive possibilities of trying to figure out in your own data systems or in your national registries. I see that now happening in the registries in some of the Scandinavian countries, where when you really can compile the data of many patients and their underlying situations, that you can actually predict whether a certain risk is available in your patient population. And you could be able to do that real time. Again, nurses who are online know this already. You do your prediction of bed sores and you try to identify which patients are at risk. What I'm thinking is optimizing all the knowledge that is in the databases of registries available, and make that available directly in the consulting room to help you to assess a situation, rather than having a huge lag time of 6 months or a year before you see the aggregate data.
Thanks, Niek. Helen, do you want to speak to the issue of community engagement? There's, of course, a lot of talk about patients and families having a role in both the design of measurement and contributing to the understanding of what's going on. What's meant by community engagement?
I think that's a good question. It's something that we have not done a lot of. I see it as sort of rolling up the individual data that we have and presenting it to the community. We have some good models of community engagement, actually from Ghana, one of our participants in Salzburg, where they have community councils to whom the hospital reports, and the councils take complaints, and they issue a report card for their community facilities. I think there are a lot of unanswered questions as to how we manage any of this, both with the larger community on one side and then the expanded idea of a health system on the other. So how do you bring in providers and office-based care into the measurement system, into a global measurement system that you can then feed out to a broader base, not just individual patients, but their communities. But I think it's doable. I think it's something it's an exciting concept, and it's something that we will need, to really have a lot of thinking about, because we're in a position to design these things from the ground up, I think.
I'm going to relate the question and your response, Helen, to another one here about distinctions, if any, apply here. When you think about the Salzburg principles, what about non-acute settings such as primary and community-based care? That seems to relate to a lot of what Helen is talking about, if we're talking about also the wider community and the continuum. Don, can I ask you about that in terms of, there are, of course, foundational issues we're all talking about these days, reliability being one of them, no matter what the setting, et cetera. But where does this tee up for measurement?
It's big. I can't help smiling to remember the co-chair of the Salzburg seminar was Tejal Gandhi, whose research career has been largely devoted to tracing this pattern in ambulatory care and primary care, where she and others have found rates of error and that are similar to in hospitals. Since people in primary care tend to be healthier than those in hospitals, the consequences are not quite as dire, but they're still important. And everything the Salzburg seminar principles speak to in hospital care apply in the ambulatory and community setting. One thing that I think is particularly relevant is handoffs. A lot of the kinds of injuries that we see, I think, are handoff problems where we just haven't built for continuity, and there are particular kinds of errors there. There's also issues of medication and medication mismanagement. And the other thing I can't help mentioning is an IHI project that is related to this, which is age-friendly healthcare. The aged, frail elders are particularly vulnerable to these kind of injuries and errors. And in the age-friendly healthcare, and you can Google that, maybe Vicki will put a link in, you can find the framework, because now 650 American hospitals are engaged in the age-friendly health system work, and that definitely gets to community-based facilities, the monitoring and care of elders in the community. So it's all of a piece, and it's a really important arena.
Thanks, Don. And those of you who are contributing on the chat want to thank you. We still have some minutes for questions. I want to call out Hardeep for putting out some sort of ideas here. an electronic way to look at triggers, both for retrospective and prospective measurement, and has offered a link from the BMJ Quality and Safety in Healthcare. Thanks, Hardeep.
Hardeep was a big participant in Salzburg as well. Nice to hear.
Oh, fantastic. That's great. Nelda has asked an interesting question, which I can't decide if it's a riddle or not. She says, I noticed that the journey of the patient was mentioned. When does the journey of the patient end? Is it related to discharge, or does it ever end due to the fact that the patient may return to our facility? Helen, is that something you would like to reply to, you or Nick?
Yes, I would. I don't think it does end. I think that what we need to capture, and we have, some of this, for example, in our state databases, is the entire healthcare journey of the patient and what's the long-term effect of their healthcare treatment. I think that's really the Holy Grail, right? To find out what effect things are happening in the long term. I mean, just using medical injuries as an example, people can be they may survive and they leave the healthcare system in which it happened, but it affects their entire lives for the rest of their lives. And that's not really captured. What are the effects of things, and how well do things really work? So to me, it's really exciting, the idea of capturing the entire patient journey.
If I can react, Madge, I fully agree with Helen, and also want to say if because I saw the remark from Nelda in the chat, a country has a personal health data environment, and there is an increasing number of countries that set it up. So apart from your electronic health records with your healthcare provider, you have your own health data space, and you can put your data there from wearable or whatever other way. You can, of course, share that data with whatever provider you want, but those data can also be made available for risk assessment and monitoring. And yes, that never stops. That would be a way of documenting your own health data, but as a citizen or as a person, you can decide that those data are part of a bigger whole that will help monitoring safety and risks and getting signals in time. And of course, that needs careful handling, but I see now several countries moving in that direction. And it's very important to put safety as an element in that discussion, not just see it as commercial opportunities or only for specific diseases an approach, but think through how that can really help to monitor things that provide important signals for safety management.
We apologize. There seem to have been some technical difficulties, so we'll have to end our Q&A now. Thank you for joining us, though. We hope you enjoyed today's program. We encourage you to sign up for the IHI membership program. Members get free access to all virtual learning hours as well as other benefits. To learn more, visit ihi.org/membership. And thank you to our wonderful speakers, Don, Neek, and Helen, for joining us today. And thank you all. Have a great day.